I'm here to just talk a little bit about inborn areas of immunity and immune deficiency in the pediatric world in particular. I know that's maybe not a focus for a lot of people in the room, except for potentially Andrea, who you heard from this morning. We're going to touch a little bit about Andrea and her. Can I stand here?
The picture.
Oh, the camera. Gotcha. Okay. And I'm like not even tall enough for this. Okay. I need a stool, guys. Okay, we're good. Okay, perfect. Okay, sounds good. So you know what? There we go. That's better. Now I can see everyone. So, all right. How's that? Okay. So basically, I'll tell you a little bit about what I do and what pediatric inborn areas of immunity the world looks like right now. And I want to give you a snapshot because I really think that our field, we use this buzzword in medicine called precision medicine, and the field of immune deficiency is really, I think, at the forefront of precision medicine. I know Bruce might have talked a little bit about some of this basic science research, but it's really amazing to be a part of this field. To see where we can actually learn about patients and how their immune systems function and actually tailor therapies and treatments and advocate for those types of treatments that are tailored to them and their immune system, and what their underlying pathogenesis of their diseases. And so I want to give you a little bit of a snapshot into what that's like for the pediatric world. So I like to start most of my talks with this young boy who people may know. I think when we think about immune deficiency, especially primary immune deficiency, or the new term that we use now, inborn areas of immunity, one of the patients, we always like to talk about patient stories, but one of the patients that was historically kind of often quoted and really brought this to the forefront was this young gentleman here. His name was David Vetter. I'm not sure if anyone's familiar with this story, but the kind of colloquial term, or there was or like a more kind of pop culture term about him is he was known as the bubble boy. So he had a diagnosis of severe combined immune deficiency. And that is a disorder that I know you probably heard of with Andrea's story before. And people often call it bubble boy syndrome. So he had a suit built for him by NASA to keep him in isolation because he was born without an immune system. And there's a movie about John Travolta made about him, and there was him and his family really brought pediatric immunodeficiencies to this kind of to the forefront. So if you're interested in learning more about his story, I encourage you to learn more. But that's a couple of pictures of him right there, just to start up our talk. So what exactly are inborn areas of immunity? Really what they are, and the reason why the term has kind of shifted from primary immunodeficiency to inborn areas of immunity is that we're increasingly recognizing that the immune system has single gene defects, so errors in the genetic code of patients that are causing specific defects within their immune system. And we can identify these with great precision. And that can result in the syndrome or the clinical symptoms of an immune deficiency that can present in a multitude of different ways, but some of the ways that they can present are infections, cancer, or this term that we use called immune dysregulation, where the immune system is unable to regulate, unable to turn off itself. So those are the kind of constellation of symptoms that we might see in inborn areas of immunity. Like I said, it's a really exciting time in clinical immunology. We have now at our fingertips, available for clinical testing, the ability to order genetic testing for patients. So patients come in, even actually when I started my fellowship, when we initially would see patients, we would traditionally take a history, learn about the patient, do a physical exam, and come up with a differential diagnosis and we would send off kind of genetic testing one at a time. We would say, okay, we think it's maybe this. A lot of the genetic testing wasn't available very readily. It would only be available through research testing. Now we're in this era where we actually can just send off huge panels of genetic testing without kind of any sort of quite easily. Like I can do that in the day in clinic a couple times without trying to contact researchers all across the world with a particular differential, and I can send off a huge panel of genetic testing looking at 600 and plus different types of possible inborn errors of immunity with a single blood draw. And so that type of testing has allowed us to diagnose faster and diagnose with more accuracy. And that really has changed the field of clinical immunology, because we have now noticed that there are over 400 different inborn errors of immunity. So if we think about when we first the first immune deficiency ever to be diagnosed was something that you've probably heard about this morning, ADA deficiency SCID. And then we have the ability to get next generation sequencing, which is this arrow down here. And then you can see now in the modern era, we went up to 182 to now 400. I think the most recent iteration was about 600 different disorders that can result in changes in the immune system. So what does it actually entail? Like, what is the immune system? I just wanted to kind of cover this. Like I said, I'm a part-time educator as well too. I teach medical students, residents, fellows about the immune system. So I'd like to do a little bit of that today. So what's actually happening here? So the immune system, as we know, it's a collection of specialized cells and molecules within our blood system that essentially provide our defense against different bacteria, viruses, parasites, and also monitor for things like cancer within the body. And then it's also made up of kind of the barriers of both physiologic and anatomic that we have on our body. So we think about our skin, for example. The skin is actually part of the immune system as well too. We don't naturally think of it. We always think of it as the blood system, but patients who have issues with their skin, they often have issues with lots of recurrent infections. And so we always have to think about not just the blood system, but we think about the whole body as a whole as well too. Just in interest of time, I am just going to kind of whiz through this a little bit, but essentially when we talk about the immune system, there's a few different layers. There's the innate immune system, which is a very non-specific defense where we start to where these cells in our blood system non-specifically are able to trigger and say, hey, there's something going on. And then there's their adaptive immunity, which is a bit more of our specific defense, where we make antibodies, where we make specific T cells to fight very specific viruses, and that's viruses or bacteria, and those are all part of the collection of cells that wake up our immune system. And then the really important thing is that our immune system has to be able to turn itself off and regulate itself. And we really are increasingly understanding that's one of the more integral parts of the immune system. It's also a way that we are understanding that immunopathogenesis or defects of the immune system don't just land in immunology clinic, but they also land in a lot of different clinics. For example, gastroenterology clinic. I'm sorry, I'm just trying to advance the slide a little bit faster there. But gastroenterology clinic sorry. There we go. I'll just leave it there. So they land in things like gastroenterology clinic or rheumatology clinic, where we understand that really severe autoimmunity, really severe immune dysregulation, where we see the immune system attacking the body, that can also be a sign of an immune deficiency. And so when we see defects of the immune system, this is often what's quoted for pediatric defects of the immune system. As we all, if people have children or have children around here, kids get sick. But we are really seeing that when kids are getting more frequent infections than the average, that's when we start to trigger and start to think of, okay, could that child in front of us have an immune deficiency? And these warning signs or red flags for immune deficiency, there's kind of two different ones that we often quote in pediatrics: the Jeffrey Modell Foundation in warning signs, as well as the Immunodeficiency Canada red flags for primary immunodeficiency. Those help us determine whether the child or patient in front of us has an immune deficiency. So so where are we right now? Like I said, this is the most recent kind of update of the classification of different immune deficiencies. These are all the different types of categories of immune deficiencies that we see. Again, they're all kind of grouped and divided based on what cells, what specific parts of the immune system could be defective. Often they're diagnosed nowadays via genetic testing, and we can fit them into these particular categories. And it allows us to be super precise and in our treatment and management of these patients, and advocate for things like very specific therapies, which we'll get into just shortly. So I'm going to shift gears and talk in particular about severe combined immune deficiency. You may have heard that. You may recognize the young gentleman in the middle whose story you heard this morning. And so I know Andrea must have mentioned the patient story side of it, but I do want to mention a little bit about the science behind about his treatments, and and kind of some of the practicalities about severe combined immune deficiency and how far we've come with this particular disorder. So severe combined immune deficiency, like I said, is what we would call, colloquially, the bubble boy syndrome. Again, these are patients that have issues with that are born with congenital defects of their immune system that are quite severe. They actually, the way that we define it is that they actually don't make a really important cell of the immune system that we call the T cell. Okay. So all of these three young gentlemen that you see are all Albertan patients. They were, so a couple things that I just kind of want to highlight about them. You'll notice they're all infants. So they were all diagnosed very early. And in the modern era of severe combined immune deficiency diagnosis, we're actually able to screen and pick up for these disorders right from birth. So we're actually able to diagnose these children very early, which has greatly impacted their management. We've also what you'll notice for them is they're all boys. We do see a higher predisposition of severe combined immune deficiency in boys. That's because a lot of, now we understand the genetics of severe combined immune deficiency, we know a lot of it is what we call X-linked. So it's more going to be affecting boys rather than girls, but not to say that girls are not affected. Yeah, we're going to get into all their stories just very closely. So I'll just you've met and you learned about Jacob, who's in the middle there, but the other two boys are young gentlemen who were both the two on the right. So Jacob and Hudson is another young boy who were both diagnosed with severe combined immune deficiency via our newborn screening program. And then this is Kishore. All of these boys are kind of over 5 now. This is when I started, but he was diagnosed based on his family history. So he had an older sibling who passed away in India, who was undiagnosed with severe combined immune deficiency. And because of that family history, we were able to make an early diagnosis for him. But he was actually born in the era before we started newborn screening. So we had to rely on things like newborn family history of severe disease or early infant death to help increase the diagnostic suspicion, which is obviously not a route that we want to rely on. And like I said, all these have the same issue here going on. They lack this particular cell count called a T cell. So you can see all of them are quite low. This is just an example chart from them. So I just wanted to talk a little bit about what the natural history of kids with SCID or severe T cell defects look like, because what can make this a really challenging diagnosis is that children appear completely normal at birth. They actually don't have any sort of symptoms. As Andrea probably remembers with Jacob as a baby, he looked pretty normal, right? He had a feeding tube and he had a few issues, but he looked really normal. And unfortunately, it's not obvious till it's obvious. So what ends up happening is these infants before screening would just go to their pediatrician, kind of grumble along, not gain weight properly, have lots of infections, and then suddenly they'd be in the ICU with a really severe infection, sometimes on a ventilator, sometimes requiring, and then would need emergency treatment, and the diagnosis would be obvious at that point. The unfortunate thing about severe combined immune deficiency is that if we don't institute a treatment within the first 2 years of life, it is universally fatal. So this is where we've come. So we're up in the 2020s now. the first time we've ever diagnosed, the first kind of clinical literature about severe combined immune deficiency was back in 1950 by the Swiss paper. You'll see this is what they called it. That's why it's in brackets, because it was in a different language. It was published in German initially, and so this is what they called it. Later, we were able to diagnose that, okay, potentially immune deficiencies could be related to genetics. This is kind of later in the 60s. We were able to understand that. We then diagnosed the first immune deficiency and found the genetic defect for that in the 70s. That's ADA deficiency SCID, one of the first types of immune deficiencies we understood. Then, of course, is David Vedder's story, who didn't have, but a different type of, who kind of brought the name of severe combined immune deficiency out into the forefront, where people would kind of understand that in different households. Then we actually had another kind of breakthrough in 1990. This young woman is named Ashanti De Silva. She was actually the first person to receive gene therapy for any disorder, any human disorder. And she also had ADA deficiency SCID. So again, in primary immune deficiency, pediatric immune deficiency is really at the forefront of these precision medicine technologies, where we're able to change people's genetics. And she was the first human patient to ever receive a gene therapy kind of product, if you will. We then instituted something called newborn screening. First started in the US in Wisconsin in 2008, where on the, if anyone recalls being newborns, when the first couple of days of life, they get a little heel prick, and it screens for a bunch of disorders. And one of them now is severe combined immune deficiency. And it's just done by a blood spot. So we just do a little heel prick on the infant's heel, and then it just, they take that blood and they do a bunch of blood spots on this card, and that cards get sent to the newborn screening lab, where they're able to screen for numerous amount of disorders. A lot of them have to do with metabolism, that's another group of disorders known as inborn errors of immunity. We also screen for things like sickle cell disease and cystic fibrosis. But in 2008 in Wisconsin, we were able to start screening for severe combined immune deficiency, and that started in Canada a little bit later. And now we're kind of in 2020 in this era of precision medicine. So just a quick kind of shout out about what this screening is like. So this screening measures, there's a lot of, it's not an immunology talk without complicated arrows and cells pointing to different things. So, but I just highlight to the picture. So this is Dr. Jennifer Puck, who works out of UCLA. She pioneered this technology for screening for SCID. She really was one of the forefront to say that this would be an appropriate test to do. As you can see, we can test this from the blood spot, and it only costs a couple dollars per sample, so super easy to implement on a population basis. Yeah, of course. And essentially what we're trying to test is does the patient have the machinery, and is there, do they have the process of making T cells? Because we know severe combined immune deficiency is about not making T cells. So we're trying to just measure that process. And what we are actually measuring is a garbage product of that process. So this is what we're measuring, this circular DNA that is a kind of a garbage product if there's good T cell development. So if people have lots of garbage, they probably have lots of good T cells. If they have low garbage, they have probably not good T cells. So it gets flagged to us when those cells are low. So that's what the screen looks at. But we'll keep going there. And this is where we are in Canada. So we in Alberta started in Alberta in 2019. Ontario was the first in Canada to start in 2013. I should update this slide, shouldn't I? Because we're already in 2024. So Quebec has started now. So the only region we're not screening is Newfoundland. And, you know, that's things where we think organizations like Immunity Canada can really come in, because really this is what we're trying to harmonize and advocate for care. And we know that screening and early diagnosis for patients really changes their outcomes. So really changes how they go through transplant and how we're able to start therapy. And so getting every infant in Canada screened, I think, would be a reasonable goal for national organizations such as this. So like I said, we started in 2019. We because we are the northernmost city in Edmonton, in the northernmost capital city or kind of tertiary center in all of Canada. We often have patients from our northern territories. So we screen all of the Northwest Territories as well through Edmonton, as well as the western part of Nunavut. So we're covering a huge part of the landscape in Canada. But because many of the northern communities will send a lot of their labs down to the provinces in the south, we have covered most of the north that way. So really the only one that's left is Newfoundland here. So I'm just I just brought this story up again because I wanted to contrast a little bit about how, screening has impacted care, but we're still kind of, even with early diagnosis, there are a lot of still barriers to getting access to precision medicine. And I'll use Jacob's story again, but I wanted to highlight it when it does work okay. So I'll highlight both Hudson and Kishore's story for you because they have the same diagnosis. They were diagnosed very early. So this is Hudson's story. He was diagnosed at day of life 5. So he was 5 days old when his screen was positive. The following week, we were able to send off for further testing, which kind of confirmed that he had SCID. And then we were also very suspicious about the type of SCID he had, which was X-linked SCID. Okay. And that's a fairly common type of severe combined immune deficiency. Sorry about that. Keep trigger fingers here. We were able to start him on isolation precautions. So that means where he stays at home, only has a maximum of 4 caregivers, get supplementary therapy like IVIG, start him on antibiotics to prevent certain types of infections or fungal infections, and confirm his diagnosis via genetic testing at 6 weeks of age. And he was what we would consider born at a lucky time, because at the time he was born, there was an open trial available for gene therapy for X-linked SCID. Traditionally, kids with SCID are managed by a bone marrow transplant, but increasingly we understand there are types of SCID that may not be eligible for a good bone marrow transplant or may not have a good match. So we're trying to institute more and more of these precision therapies. And so because he was born at the right time when the screening started and when there was a trial available, he was able to travel at 9 weeks of age. And he was actually one of the youngest on the St. Jude's trial because of the screening. And he got his kind of gene therapy at 11 weeks of age. So that's like an incredibly fast timeline, much faster than we would have had before screening. When kids are typically diagnosed at 3 to 4 months of age. And the fact that it was available on a trial made it easy to access. So that's X-linked SCID. You have already heard Andrea's story and ADA deficiency SCID, but this is the contrasting timeline. And this is when we run into roadblocks, right? And this is where I think national advocacy for precision therapeutics is really important. We were able to screen. It's kind of same timeline for diagnostics because we have the screening in place. We have access to genetic testing, right? So we have the diagnosis by 6 weeks. We can even start things, especially for ADA deficiency SCID, special medications called enzyme replacement therapy. But then because the particular gene therapy for ADA deficiency SCID was no longer on trial and no longer available, we hit this roadblock. And that's where you heard Andrea's amazing advocacy work before. I'm just going to skip over this just in the interest of time. So what is happening with ADA SCID therapy? So why is this not easily available? Because once it's off a trial, what we're left to is either the company, will the company apply for Health Canada or FDA approval so that it'd be available. So that didn't happen with ADA deficiency SCID. It only underwent European Medical Agency approval, which is why the traditional ADA deficiency SCID therapy was only available in Milan. There was also some side effects associated with that therapy, which may be also some of the reasons why it didn't undergo FDA or Health Canada approval. But also, we also have to have, when we're reliant on industry funding and industry in terms of getting these therapies from trial to access, we're relying on industry motivation. And so what ended up happening, as you probably heard with Andrea, is that when the company that had the rights to this therapy, they kind of decided, you know what, this is not going to be something that they're going to move forward anymore. This is where the work of incredible advocacy, which I'd like to highlight with Andrea's picture, because she was actually incredible and changed kind of the landscape for patients with ADA deficiency SCID across North America. And I don't know if she tooted her own horn enough, but I need to do that for her, because she was incredible. She spoke to she spoke to politicians, she spoke to journalists, not only in Canada, in the US. She used her voice, she used her son's story to say, hey, this is something that needs to be done. We can't leave these patients untreated. We can't leave it to the will of just the drug company saying, yes, I'm interested in moving this treatment forward, or I'm going to shelve this treatment. It has to be something that comes from patients. And because of that work, she was able to, that treatment was, the rights to that treatment was able to be moved from industry back to kind of the researchers, back to California, in particular UCLA, which is where her son ended up getting the treatment finally at 4 years of age. So I just really do want to, I know she probably showed you a lot of these photos, but I need to show them as well too, because they're just the best. And that's of course Dr. Don Kahn, who pioneered this treatment, who is wonderful and is a great advocate. But yes, now he is kind of able to run the trials with the new types of vectors and the new types of therapies, so that more kids can be treated. So that's all I wanted to talk you to about. That was kind of a whirlwind, but this is really what I wanted, our snapshot of what pediatric immunology is like. We are now able to diagnose patients early. We have genetic testing to be able to diagnose with precision, and we can now ideally access precision medicine. Of course, though, access to therapy is something that's easier said than done. So theoretically, now that we're at this forefront, I think the next step is to say, okay, we need to advocate. Now that we can advocate for we have accurate diagnostics, we need to make those diagnoses meaningful to our patients, so that they can access therapies that are precisely for them. They're made for their particular immune system issue. So this is a stolen slide from Dr. Nicola Wright, one of my collaborators in the University of Calgary. So this is hers, but this is just a snapshot of all the different types of gene therapies that are available or kind of in different stages of development. Some of them are preclinical, some of them are under clinical studies, and some of them, the only one right now is still the therapy that the ADA deficiency SCID therapy in Milan. Dr. Kahn is still under a trial, but hopefully once he has enough kids, he undergoes FDA approval, and then that also will be available just clinically outside of a trial. I just want to highlight there's a few that are actually Canadian, homegrown, and we think that this might be one of the solutions to getting access, is because when we have to send patients out of country, that's always a little bit more difficult. We have to advocate to our provincial healthcare systems that this is something that needs to be done. It has, it's often something that patients themselves can't pay for, so we have to advocate for public funding that this is important. So it really might, access to homegrown therapies or deficiency types of therapies that are available in Canada might be a better solution to that. So we do have these precision therapies available in Montreal for a different disorder called chronic granulomatous disease. Dr. Wright is starting studies looking for a different type of treatment for a different type of SCID known as CD3 delta SCID that tends to affect our Mennonite populations more. And PNP deficiency SCID is being looked at the University of Toronto. So lots of exciting times. And yeah, we'll leave it at that. And I'll open up to questions. Yeah.
Thank you so much.
Yeah. I'll continue to stand here because I know there's a lot of people.
Yeah. Are there any questions in the room and any online?
Is there going to be chat?
Helen?
Hi.
Oh, sorry.
Thank you very much for the talk. Just a quick question. You're testing now for SCID, pre-screening for SCID. Will those tests eventually also include something more like common variable?
Yeah. Yeah, that's a really great question. Yes, of course. So the question is we're now screening for severe combined immune deficiency. Do you think, are we moving towards screening for other disorders like common variable immune deficiency? It's a bit of I'm going to give you a bit of a long-winded answer, sorry. So in some centers, we actually so common variable immune deficiency tends to be a disorder of B cells, a different type of cell in the immune system. So different from severe combined immune deficiency where the primary problem is the T cells. But we are able to kind of still measure via that same test, kind of the garbage byproducts of B cell development. However, they're more going to pick up not common variable immune deficiency, but potentially more severe B cell immune deficiency. So there's another type of disorder called A-gamma globulinemia, where patients are not born with any B cells instead of developing dysfunction of their B cells later on in life, which is what CVID would be. And so there are centers, actually a couple at Saskatchewan, when they introduced their screening, is also screening for B cell disorders that way. It's not, I think the science needs to be worked out a little bit about how accurate it is. So there's that. The other kind of way people are thinking about screening is that actually using, that genetic panel that we would send off in clinical tests, but actually using that on the blood spot or using that as a screen test. Because now the technologies come so that you could potentially send off genetic testing, direct genetic testing on the blood spot as well. Again, very preclinical, not like ready to be phased out. But yeah, there is a day where we might be able to diagnose, at least define genetics or B cell deficiencies that way. Common variable immune deficiency is a bit tricky because there's sometimes one single gene associated, but often there isn't. So then that may not be amenable to the genetic testing. And then the B cell deficiency, because sometimes it can be progressive, can be okay at birth. We don't actually diagnose a lot of CVID in pediatrics. It's more of an adult disease. That's when patients tend to present. It may not be something that we can pick up right away because the manifestations may not be evident till later on in life. So yes and no for that. Yeah, but great question.
Just a follow-up question.
Yeah.
Then the red flags that on
the
presentation, doctors are maybe starting to screen out using that because it's such a rare disorder that I'll be honest, I've talked to some doctors and watching.
Don't know. Yeah. I think it's a great question. A lot of those red flags, like the Jeffrey Modell ones, are definitely focused a bit more on pediatric presentations. Immunodeficiency Canada does have a list of red flags that are focused for adults. However, are they as well known as other ones? I think one of the things where we we don't, I think in pediatric or immune deficiency, I think a lot of people think of it as a pediatric disease because it's like, if you're born with an immune system problem, it should be evident from birth, right? But we know that's not the case at all. We know that most of our very common immune deficiencies, CVID being the main one, is actually more prevalent in adulthood. We also understand that there's lots of different disorders that don't present until at least after 10 years of age, if not early adolescent later. But yeah, it's a great question. But those red flags, I think, could be, or like adult specific red flags that are more kind of widely propagated or introduced into medical education would be helpful. If it helps, I teach the medical students, of which we're trying to do at the end of medical education is train good family doctors. So I do talk about immune deficiency, but of course that's Edmonton specific. But yeah, we do try to introduce it into the curriculum so that students and physicians are
earlier the diagnosis.
Agreed. Yes. Agreed. Yeah.
So as someone not living with me,
Yeah.
or as a friend of them, really basic two connected questions. What are we finding in terms of numbers?
Yeah.
Newborn.
Yeah.
Screen, and are we seeing across the world, like many other things, not just related to the screening, but are we seeing an increase?
Yeah, that's a great question. So I know Bruce touched very briefly on the registry. The thing that we don't know in Canada is our numbers, right? We don't know our overall numbers, and that's part of the registry project, is to understand that. For SCID, we're a little bit, we can make a little bit more of a guess. I think I went through this slide really fast. Sorry, I'm trying to find it. The number slide, I don't know where it went. But just in terms of when we started screening, it must have gotten hidden. I had, so essentially what we think, we're in Alberta, what our incidence of SCID is, what we're estimating is 1 in 20,000 to 1 in 30,000. So on average, 1 to 2 SCIDs, new SCID diagnoses per year. True severe combined immune deficiency, as now that screening started, that's what our estimate is. But in terms of overall numbers, we don't have good numbers, and that's a project that both Dr. Ritchie and I are involved on, is the Canadian registry study, where we are trying to understand both severe combined immune deficiency plus other immune deficiencies. What are our numbers in Canada? How many do we have? And that's a national project that we're all kind of involved in. Adult and pediatrics, we don't have good numbers. We can estimate for SCID because we screen every infant, but we don't screen for anything else, right? Yeah, good question.
Thank you so much. If there's no other questions, thank you so much for that presentation.
No problem.
Yeah.
Thank you.